Yeah, now you can share the screen.
Okay.
See, uangalie email.
Hold it a second. I have to get back to my PowerPoint here. Can you see it, or did I go too fast?
Not yet.
Oh. Okay. Sorry. There was a little thing I should have clicked. How's that now?
Now, yeah, we are seeing your screen.
Okay.
So, are you seeing my slides again?
Yes, yes.
Excellent. Okay. So, if I wanted to treat some tumor, say that's in the pelvis. So here we have a treatment of a prostate. I have this radiation beam coming in. If I tried to treat with just a single beam, and I wanted to give 100% to the Are we getting an echo here?
Sorry,
Yeah.
it's a Murua's device. Yeah, and forgot
okay.
to mute.
So if we tried to treat with a single beam, we'd be giving most of the radiation actually at the surface. So we wouldn't be treating the disease, we'd be treating and getting a lot of complications because of this. So the trick then is to actually not treat with single beams, but to treat with multiple beams coming from multiple directions. And that's why these machines are made to be able to rotate around the patient so that we can bring in the radiation from multiple directions, always aiming at the target from each of the directions and shaping the radiation beam so that it is just covering the target. And we'll look at that in a second. So this is the approach to get that dose at the target at depth. And one can treat from perhaps 4 directions. That was very common and is still common for some diseases and was very common for all diseases 10, 20 years ago. And now we often treat with many, many more beams from many directions. And in fact, I'll show you in a second that in many modern treatments, the device is treating while it's rotating continuously. So why does why is this penetration different? Why is the penetration of different beams different? What's going on here? So let's look at a little bit of the physics of this. So I have photons coming in, and they start to interact with the medium, with the material that they're passing through. And in their interactions, what will happen is some of the photons will scatter, and we'll look at some of the interactions in a second. But some of the interactions will create high energy electrons. So there's going to be some ionization of the medium as the photon passes through. And these high energy electrons will continue downstream, they'll travel downstream. And as they're traveling downstream, they're losing their kinetic energy and they're giving energy to the medium. And that's going to further ionize other atoms. It might cause some excitation. This ionization and excitation will have chemical outcomes. There will be, especially if this is happening in water, and many of our, much of our tissues are have a lot of water in them. So we get a lot of radiolysis, radiation chemistry happening in the water. There's a creation of a lot of free radicals and all kinds of breaking of chemical bonds. And that will, again, hit particular important molecules in the cell, and that will create the biological damage. So these photons are indirectly ionizing, but it's these charged particles that are being created that deliver energy into the medium. What are some of the reactions? Well, there's 5 interactions that high energy X-rays can undertake as they're traveling through the medium, but the main ones in medical physics are the photoelectric effect, Compton scattering, and pair production. And I'll just look at Compton scattering just to give you an idea of what's going on. The photon comes in and it interacts with a free electron that's has an energy a binding energy much less than the photon energy, and we get a recoil type of reaction, much as you might get on a billiards table, where the photon will scatter on a certain direction, but it will give some energy to this electron, and that electron now gathers some high energy and will travel through the medium. And it's this electron now that is going to be giving energy to the medium. This photon might still have very high energy, and so it will interact further down into the medium. So we have this chain of reactions that are interactions that are happening, and the probability of these interactions happening depends on the energy. So this is what is the probability of a certain interaction happening per unit mass of material. So this is a physics characteristic of a particular element, and it's showing what the probability of interactions are, and these are the different interactions at different energies. And so here we have the energies that are used in diagnostic radiology, and here we have the kinds of energies that are used in radiotherapy. And for lead, the shape is something like this. Again, there's a certain probability of the interaction happening. And if you look at the relative importance of these interactions, in much of radiotherapy, it's Compton scattering that is the most prominent of the interactions that are happening. And in diagnostic radiology, what we do delivery of the dose is because energy has gone from the photon beam to these high energy charged particles that then travel through the medium and deliver their dose to the medium. And again, this is just an illustration of that. And so that's a bit of an explanation for why the dose is not the maximum at the surface, why it is at some depth. As the photon beam comes in, it starts to interact. Here, photons start to interact at the surface already, but the electrons that are created are traveling downstream, and they're giving their energy further down, and that energy that's given is what is the dose. And in fact, one can calculate what the dose from a photon beam will look like by looking at what is the probability of these different interactions happening: photoelectric effect, Compton scattering, pair production, and looking at the energy that goes from the photon beam. Remember, E equals HU is the energy of the photon beam, where we have Planck's constant and the frequency. And so the energy of the photon beam minus in the photoelectric effect, I have to overcome the binding binding energy of the electron that I'm injecting. In Compton scattering, I have this recoil happening, and some energy is going to the charged particle. And in pair production, the energy is loss that goes to charged particles is because of the energy of the pair electron and positron pair that you're creating. So again, there's a lot of physics here in a introductory medical physics course. we would derive these equations, but one can calculate what the energy is that's given to the medium, what the probability is of energy being given to the medium from basic interactions of the physics interactions. And just to remind you, what is the dose, the unit of dose? Dose is defined as the energy absorbed per unit mass. So it's joule per kilogram is the definition of the dose, and that's given the name of a gray. So 1 gray is 1 joule per kilogram. Actually, and I'll just point out that if one looked at the energy increase in a glass of water, if you gave that glass of water 1 gray of radiation, the temperature increase because of that 1 gray is less than millidegree Kelvin. So definitely the damage is not because of heating, the damage is this molecular damage because of the chemistry and the radiation chemistry that happens. Just to go back again, these are what the penetration of various radiation beams look like. I've shown you this curve. As we increase energy, photon beams get more penetrating. One can treat with electron beams on many of these linear accelerators by removing the target as the electrons have come through their path. If we remove the target, we can actually treat with the electrons themselves. The dynamics of that treatment is very different. The interactions are very different. These are charged particles penetrating through. Eventually they lose their energy and eventually they stop. So these electrons, when we're using them to treat, only penetrate to a certain depth. So these are often used to treat superficial disease. And then there are other particles that one can use. And Daniel was telling me earlier today that you saw a little show on protons. And again, this is the same thing, charged particles that eventually lose their energy and stop completely. Okay, so I'm gone on for a long time. I do have more to say, but I'm wondering, do you want to have a 2-minute break or how are we doing?
Yeah, a 2-minute break would be a good idea. So
okay, well, why don't we make it a 5-minute break?
Even better. Members, let us break for 5 minutes. Let us recharge our energies and come energized. Thank you. How are you holding out, Yakov?
Okay, pretty good. Good talk. I mean, I like the story. I mean, it's good.
Yeah, well, while I was preparing it, I thought we were encouraging Daniel to keep it less than an hour. And then I thought, if I wanted to do this really completely without too many shortcuts and lies, maybe I'll just take advantage of the long time. So
yeah, I find that well, I mean, it's hard for me to tell, because I'm not trying to understand everything you say. I mean, I don't know how people receive this when this is a totally new subject for them. But I think the storyline, I think it's important. Yeah. And that takes time. You cannot, quickly go from one to another, and that's.
Yeah, so when I was putting these slides together, what I found was many of the sources were talks to different audiences, right?
Mm-hmm.
And so some would be more detailed, some would be less detailed, and then as you try to knit all these things together, you find, well, if I say this, I have to say this, and then I have to say this. Anyway, I'm going to see if I can refill my coffee quickly, and I'll be back in a second.
What's your impression, Daniel, about the flow of the talk and things like that?
For me, I
Do you
think
find it too fast, it's too much, or too little?
no, I'm enjoying it. When it is like this, it's perfect.
Good. I think it's important for us to get feedback from people in the audience, both students, faculty, and so on.
Yeah.
Because that helps us, do better, kind of finding the right angle of what we say.
Yeah. Maybe I can read some students say how they are faring so far. My friends, you can come.
Okay. Okay.
You are a student?
Yeah, I'm a student at Mary University.
What year? What year?
Year 2, semester 2.
Second year?
The second year, the second semester. Eugene.
Okay.
I'm Eugene Macharia, and I have passion in medical physics, and that's why I find it interesting when I'm studying it, and that's why every time I'm purpose to attend these sessions. So it's really interesting, and it's good. Yeah.
Do you find the presentations too fast, too slow, too obvious, or too difficult to understand? Or at this point, we are not trying to basically teach you all the details, because as you can see, each one of those slides probably would require a full few hours of lecture and exercises and so on. But at this point, our main purpose is to get all of you a sense what medical physics is, because the ultimate goal for us is that you become medical physicists, and it will take. John, while you were out, I mean, what's your name?
My name once again is Eugene.
Eugene is a student. We were asking, how do they feel? I mean, if this is understandable, it's like too obscure, too obvious.
Oh.
And Eugene said it was too obvious, or?
No.
Is it exciting, Eugene, or is it boring?
Okay, the presentation is exciting, and you might introduce new things. Of course, it might be hard, but we are trying to cope up with things, and you are trying to learn. It's a process of learning it. You might not find everything easier, but at least after this, you are taking small notes, and we are trying that we capture up with you. Yeah. So it's a bit interesting, and at times we find new things, of course. But I can say that you are trying. You are really trying. Yeah.
Well, that's good. That's good. I mean, in an overview lecture like this, obviously, the speaker is always throwing out things that'll, if you had a few moments, you would want to hear a much longer story. But this story or the story that I'm trying to tell today, I'm hoping to tell it in a way that I get you interested, and that one or two things that I say, you'll say, oh, that really looks neat. I need to understand this. And then you go and you do a little bit more, or you ask the question at the end. But I will say the purpose of this lecture was to say enough to get you really interested, but not to tell you so much that you think it's oh, that's too easy, and I'm just going to stop now. So I'm trying to it's a hook. It's like I'm fishing, and I'm trying to hook and get young medical physics fish in Meru.
Yo, we appreciate
That's what we're trying to do, right, Jakob?
Exactly so.
And I also, Eugene, I also want to ask, get enough things that you ask questions that you start to bother Daniel and Moa with lots of questions. So, you know, so that you keep them on their toes.
Yeah. We are teachers that we have to. Yeah.
What we hope is the at the end of this year, there will be enough, you know, organizational things done so they can start a program, a graduate program in medical physics, which will go into many of these things in way more detail, you know, like any course. If you took a course in electromagnetism or in, you know, nuclear physics or quantum mechanics and so on, I mean, you know, obviously you cannot cover that in 1 or 2 hours. You have, it's a full semester or 2 semester course, each of them.
Yeah.
Although it's in that introductory course where a professor or a high school teacher will say, well, you know, things aren't made solid. Things are all made of waves and stuff. That excites you, that you want to become a physicist to understand this, right? And Jakob, I say that because that was the exact statement that my grade 11 high school teacher said, made me think that physics was exciting. He said, you know, you really try to understand what's going on in matter. There's all these, this thing called quantum mechanics, and things are waves and probabilities and stuff. And I thought, oh, this is too exciting. So are people slowly coming back?
Yeah, we have 2 hours now.
Nice to meet you, Eugene. So did I chase them all away, Daniel, or?
No. They went back to their seats. So
Excellent.
yeah, so we are a full house now. We can continue.
Okay. So again, I apologize that this is such a long story today, but as I was preparing this, I thought if I try to keep it any shorter, I'm going to miss telling stories, and it would not be a nice story. It would just be a bunch of facts together, and I wanted to tell a story.
Very exciting.
So let's continue now, and I'll talk about how do we do the radiotherapy? So how do we treat Mr. Smith or Mrs. Jones as they are coming into the cancer clinic? And so there's a number of stages to the treatment of the patient. The first stage is trying to figure out what is the target, where is the target, where are the other organs. So we have to do some kind of identification of the target so that we know what we're trying to treat. And then we'll try to figure out how do we bring in the radiation beams so that the dose goes to this target and not anywhere else. And then we have to figure out how to transfer that information from that plan to a treatment machine that, and then we do the treatment delivery, and then we'll make sure that everything is happening. And so these are various stages in the treatment, and the medical physicist is involved in all of these stages. I do have a little thing here, and it's just a reminder that for most patients, they don't just come once, they're going to come multiple times. We treat with a little bit of radiation over an extended period. And we're doing that for a number of reasons. One is if we do this, this process, it's called fractionation, we actually give the normal tissue the ability to repair itself, and so it's not as damaged from the radiation. Whereas the tumor cells, which are dividing much more quickly, that's one of the natures of tumor cells, is that they're very aggressively dividing. They don't have time to recover as well, and so there's more damage that's accumulated in the tumors than in normal tissues. One thing I will say, if we gave that kind of dose to the whole patient, the patients would not be surviving. So again, as I said before, the trick in radiation therapy is to give this to the target that we're trying to treat, and not to the rest of the patient, and not to the normal tissue. So just to talk a little bit about the process, in many centers still in the world, they would use a conventional X-ray unit to image the patient and get planar kind of film, and then a radiation oncologist, along with the therapist in the planning room, will decide how to bring the radiation beam in from a certain direction based on these planar films. So this was called a conventional simulator. It simulated the motion that a treatment machine could come by, and it was used to identify the radiation beams that you would want to bring in. And in most high-income countries, we don't use this anymore, but in much of the world, this might still be the way the treatment planning is done. And then eventually they will be treated on the machine at the higher energy. And just to put some physics again, these are the same two images of this radiation beam port coming in, but this one was done with a diagnostic tube with the energy on the order of the photon energy, effective energy would be, say, about 80 kiloelectron volts. And here the energy of the beam would be in the mega electron volts. And you can see that the contrast in these images changes drastically, and that's because I've gone from a lot of photoelectric effect interactions for this beam, and here all the beam interactions are Compton scattering. And so one moves from having a heavy atomic number mechanism for making the contrast to contrast that is essentially based on density alone. And again, that sentence is a 2-hour lecture in the medical physics course that one day you'll be hearing at Meru. These days, in many centers, the imaging to plan the treatment would be done with some kind of three-dimensional imaging system, and in particular, maybe with a computed tomography X-ray unit that can generate images of the internal structures of the body. So this is now a three-dimensional treatment simulator, either a CT scanner, a computed tomography scanner, or perhaps even an MRI, magnetic resonance imaging scanner. And that enables a much more detailed look at the internal structures and the various organs that we're trying to treat. And actually, I'll say a side thing that I wasn't planning to say. A CT scanner is giving you a map of the attenuation coefficients. So the map of the probability of the interactions occurring in space. And so this is a map of a particular physical quantity, how well the X-rays interacted as they were traveling through. That's a map in space that gives me anatomical information. But in fact, this is giving me information of how well X-rays interact with the patient as they're going through. And so I can use that same information to, if I had X-rays impinging on the patient, where would the radiation dose go? So this is a really neat kind of tie-in of the physics of the imaging with the treatment planning. So I have this map of how interactions happen that I can now use to say, if I have a radiation beam impinging on the patient, how is it going to give energy into the patient that delivers dose that can treat the disease? I should be a little bit careful and say these beams are at slightly different energies, so there are some corrections that one has to do. But again, the physicists have contributed to this, the design of this process, and have made sure that the information is put across appropriately, so that a computer then, and actually a computer system, can be used to plan what the radiation delivery should look like. This planning will generate control specifications for how the treatment machine should then deliver its radiation. What position should it be in? What should the shape of the radiation beam coming out of the unit be like? And so there's all kinds of specifications that then go to the treatment machine that enable the treatment to happen. And remember that this treatment machine you can consider as a robot. It's a robot that is going to move according to some control features that were generated in the planning process. And again, the physics team is integral to make sure that this is all happening appropriately. And we'll talk about that in the next few slides. So again, this is a CT scanner. This is a rather old image. They look a lot nicer now, a little brighter, I guess, maybe. But the patient will go, the patient is put in the treatment position, and the imaging is done so that we're imaging the targets and the organs at risk that we want to avoid. The physician will then take, usually the physician and some other professionals will then take those images, and they will delineate the targets and various organs at risk. So a physician will spend a considerable amount of time with the image sets from this CT scanner, say, and they will spend a considerable amount of time delineating various organs. So in the head and neck, they'll identify where the eyes are, they'll identify where the brain is, they will identify the target they're trying to treat, they will identify perhaps lymph nodes and various nodes that they might want to treat. They will identify various things that they would not want to treat, such as the spine. And so they do this full delineation of targets and such. And then this is sent to the treatment plan, to the treatment planning system. And in the treatment planning system, we then simulate radiation coming in from multiple directions, depending on the treatment. Again, we'll simulate the radiation coming in from multiple directions, and the system will calculate what the doses being delivered will be like. And so for in the head and neck, one would get for a certain situation, here again, multiple beams coming in from multiple directions, one will get a map of the radiation dose that would be delivered to this patient with these control parameters set by the planning process. And again, you can see this would be over the full course of the treatment. One would be giving about 66 gray over that treatment. So very, very high dose in this head and neck cancer. And here's another views from other slices in that patient. So one gets a full accounting of what the radiation would be if I delivered the plan as these control parameters have been set by the computer. And here's the same thing in 3D, again showing quite sophisticated planning that is done. Here's another example where I'm treating in the pelvis, a prostate. So how is that planning done? Well, it's a little bit that short, brief physics that I gave you earlier. The planning is based on assuming that radiation is coming in and interacting at some point, and then the dose is being given by these electrons that are traveling after that initial interaction. One can imagine that one could establish some kind of computer model where if I have some dose delivered by the photon at this spot, energy transferred to charged particles, I can look at how these charged particles are going to distribute that energy after this interaction has happened. So I have this map of how the energy gets distributed from this original interaction, and I can use this now to calculate what the dose would be if I have all kinds of photons coming in. So I can have the X-rays source, the X-rays are coming in, I have this initial transfer of energy to charged particles, and I look at how this energy is going to be distributed, and I use mathematical tricks, convolution, to calculate what the dose would be from that interaction. So I have essentially a map of how the initial dose is going to be delivered. I have this map of how that gets transferred to charged particles and gets spread out, and I get then the dose that's coming from that delivery. And it's a convolution calculation that gets done. And that gets done on the CT scan. So the CT scan gives where the interactions will happen, and the doses are calculated by summing all of these convolutions together, and one then gets a map of the radiation dose that would be delivered when this beam comes in. So you can imagine that setting up this system, again, the treatment planning system is a commercial system from a company, but before you can use that treatment planning system, the physics team will spend a considerable amount of time ensuring that these calculations from this particular system are